Hey guys, so today we're just going to talk about kids with an intoe gait, so a bit of a pigeon toe gait through there. And I'm just going to show you the types of orthotic that we basically do for that as podiatrists. So intoe gait can come from a couple of different reasons and causes. It can come from the foot itself, where the foot is actually turned in relation to the tibia or relation to the shin bone. It can come from the shin bone itself, so the whole shin bone can be rotated inwards, and it can also come from the neck of the femur and through the top of the leg, and the top of the leg is basically rotated inwards from there. One of the easiest way to tell which one it is through the direction of the kneecap. So if the kneecap is facing inwards towards each other, which is called a squinting patella, then it's coming from the hip itself. If the patella is facing forwards, but then the shin bone itself is at a slightly different angle, then it's obviously coming from that shin bone. And then if it's the foot, you'll see the shin bone is nice and straight, you'll see the kneecap is nice and straight forwards, and it'll just be the foot itself that's turned in a little bit. Now if it's in relation to the tibia, so the lower part of the leg, or the hip, then what we can use is what's called gait plates. So these are gait plates here. So it's a type of orthotic, and you can see through the front at the base of it here, it's angled. So where the kid would usually turn inwards and walk a little bit like that, basically this then stops the child from toeing off through the outside of their foot. So this here, it sits where basically the first and the second metatarsal head can just drop in, then it cuts across the third metatarsal head, and then it completely blocks out that fourth and fifth metatarsal movement through there. So when that child goes to kind of toe off throughout the outside like they would with that intoe gait, it then forces them off straighter. So it stops that whole dorsiflexion movement of those toes through there. That is basically used, through most kids, and is pretty effective. It's used and reviewed up every sort of 3 months to see how they're getting on. So something like this isn't something that we want to stick them in forever. It's a little bit uncomfortable. It's forcing them in ways that obviously their feet don't want to go at the time. So once that starts to correct through there, then we can start to remove this orthotic and just stick them into more of a standard type of orthotic that just stops at the metatarsal heads and just provides them that good amount of arch support and rear foot control that we had from a standard orthotic. That said, kids do grow out of it to a certain extent, especially women. So girls, as they do get slightly older, their hips get wider in terms of like they need to change their pelvis shape to be able to give birth, so that changes their hip angles as it is. And then you've got a few other little things as well that can just change with angles of legs, so whether they're knock-kneed or bowed-legged as well, that does change as they do get slightly older and go through different phases at the same time. So if it's slightly more extreme and you find that your child is tripping, struggling to walk, struggling to run because of that intoe, so sometimes they'll struggle to run, or they will trip a lot just for the fact that those feet, when they're turned in, they'll kick the other side of the foot rather than being nice and straight and having clearance. So obviously if they're tripping and kicking each other's foot, then it's not going to be the most ideal, and that's when then we can stick them in a gait plate especially, and that has really, really good effects. Has to go into a fairly good shoe again. The shoe wasn't want to be too rigid, because if the shoe's too rigid through here, it takes away the effect of the gait plate. So sometimes having a nice firm shoe towards the back end that can hold them in that controlled position throughout the orthotic, where we're giving them that support. And this one here, it's got a little bit of a skive, so you'll see that little flat spot through there that's tilting the foot outwards. So we still want control through the back, but if we've got something and a shoe that's a little bit more flexible at the front, it then allows this to do its work by pushing inwards. So if the shoe's not flexible through the front, the shoe's just going to allow it to rock, and it's not going to bend at that point. So yeah, again, we want to match the shoes up to the orthotic, to the issue, to the problem, and footwear is just as important as the orthotic. And I always say this, is the orthotic is only as good as the shoes that you put them into. So when your podiatrist recommends a specific type of shoe for your orthotic, if you really want to get the maximum out of it, then you need to get that shoe as well as the orthotic itself. So again, we put them into these for shorter periods of time, review it up after 3 months of basically use. If it's going good but it still needs a little bit longer, review it up at 6 months. 9 months and then 12 months depending on where they are, and how longer they need to use it and the effect that they're getting it from. Obviously doing exercise and exercise prescription, this is always really important whenever we're doing a gait plate as well, or trying to change any angles. So gait retraining and walking retraining for kids, physiotherapy based stuff if they got restrictions within their ankles or restrictions within their hips, trying to get that extra flexibility so they can afford to walk with their feet outwards that little bit more. And then again, just gait retraining, getting that into their mind with that proprioception nervous feedback for knowing where their foot is on the floor, and having that foot where we abduct it a little bit just to get it within that normal range and normal line as well. So there's a few different factors to look out for, and I guess again, orthotics are never the miracle cure for anything. They are a great aid, and I'm the first one to prescribe an orthotic if it's going to help through there, but we also need to do it along with other exercise prescriptions as well. So I hope that helps, and I hope that describes on the type of orthotic that we do for intoe gait, and that's just a good example of one that we're doing there.